Hello, and welcome to the ACR Journals on Air podcast. I am your guest host, Bharat Kumar, filling in for Vicky Shamagan. As longtime listeners of this podcast may know, gout is every rheumatologist's favorite topic, at least according to Vicky. And what's there not to like? It's probably the most evident of the intersections between immunology, genetics, endocrinology, and public health, and much more. Due to the hard work of clinicians and researchers, we're figuring out new ways forward to make gout less of an issue. Today, we'll be talking about the effect of weight changes on uric acid levels. Specifically, we will be going over the manuscript, Weight Reduction in Target Serum Urate Level, a longitudinal study of annual medical examination. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes for today. We are deeply appreciative to be joined by the first author of the study, Dr. Sho Fukui. Dr. Sho Fukui is a Japanese rheumatologist currently serving as a research fellow in the Division of Rheumatology at Brigham and Women's Hospital, working closely with Professor Daniel Solomon. Dr. Fukui earned his medical degree from Nagoya City University in 2014. He subsequently completed his internal medicine residency and rheumatology fellowship at St. Luke's International Hospital in Tokyo. He obtained a master's in public health in 2022 and is currently a PhD candidate at Kyorin University, Tokyo, Japan. His work centers on clinical research aimed at the epidemiology of gout and serum urate levels, as well as understanding the interplay between rheumatoid arthritis and kidney function. With a background in public health and extensive clinical experience, Dr. Fukui is dedicated to improving patient outcomes through evidence-based approaches and interdisciplinary collaboration. So welcome, Dr. Sho Fukui.
Yeah, hello, good to see you, Dr. Kumar.
Yes, it's great to see you. And more importantly, it's great to listen to you because this being a podcast, so we have so many different listeners and they get to hear your illustrious voice.
Thank you. Yeah, I'm very happy to have this opportunity today. Thank you.
And the pleasure is all mine, I assure you. I wanted to start from the beginning of your manuscript in the introduction. And, you'd mentioned straight from the start that the prevalence of hyperuricemia seems to be increasing. Can you tell us a little bit about why that is the case?
Yes, it is known that hyperuricemia is increasing globally, and the prevalence of the hyperuricemia is reported to be 20 to 30% in the United States, and the prevalence of gout also increased from 30% to 5% in the past 10 years in the United States. And this may be related to the lifestyle changes. As you know, several diets, such as high purine diets or sugar sweetened beverages, are well known to be associated with a higher serum urate level. In addition, global increase obesity is definitely linked to this increasing trend of the hyperuricemia as well.
Hmm. So it's not our imagination in which we keep on thinking, my goodness, there are more and more of these patients with gout and harder to control gout in our clinics. It actually is something that statistically has been found. Is this more of a uniform change throughout the world, or is this much more specific in certain areas?
It's a really important question. The increasing trend of the hyperuricemia is also happening in the many parts of the world, including Asia and Japan. And it is considered that recent increase in the serum urate levels and the hyperuricemia are greater in Asian countries, where obesity rate are climbing faster when compared to the United States. So, for example, in Japan, hyperuricemia is still infrequent in female patients with a prevalence of the 1 to 3%. But in men, the prevalence of the hyperuricemia used to be 15% or so, but now increased to the 25%.
Hmm. Yeah, that's quite a jump. So,
Yeah.
and it gets to the heart of this paper that you published with your colleagues. I'm curious, you mentioned obesity here as a big driver for these changes
Yep.
and how weight changes may impact uric acid levels.
Mhm.
Could you summarize what the data says about this relationship?
Yes. First, I want to mention about the previous studies. And the previous studies found there is a cross-sectional association between the obesity and overweight and the serum urate levels. And some studies suggested overweight or obesity may have more impact on the serum urate rather than specific dietary item. However, I'd like to emphasize here that there has been conflicting evidence on whether weight reduction improved serum urate levels or not. Particularly, it is not well known that how much weight reduction can improve the serum urate levels or by how much it does. For example, massive weight reduction, like a 20 kilogram or 30 kilogram through bariatric surgery, showed very good serum urate reduction consistently. However, some interventional studies found that a relatively small weight reduction, like 3 kilogram, did not improve the serum urate level at all. And furthermore, different intervention, like a dietary intervention, exercise program, medications, just different interventions complicated the results. And that's the reason why we did this current study. And in the current study, we analyzed more than 58,000 participants with 330,000 visits in the Japanese annual health checkup database. And we found very clear dose response linear association between weight change and serum urate change by using the restricted cubic splines. And when compared to the minimum weight change group, small weight reduction, like a 1 kilogram to 5 kilogram weight reduction, has statistically significant but very small association with serum urate level, like less than zero point 0.1 milligram per deciliter. But moderate to a large weight reduction, it's more than 5 or more than 10 kilogram weight reduction was associated with a serum urate decrease of zero point 0.3 or zero point 0.6 milligram per deciliter in total population, and their association was larger in the higher BMI group and higher serum urate group. And the results were also consistent among the gout subpopulation. And in the analysis of the patient with hyperuricemia in our study, a small weight reduction seems not useful for achieving target serum urate level. The number needed to treat was more than 60 for small weight reduction. However, we found that some patients with hyperuricemia achieved target serum urate levels by moderate to large weight reduction without using urate lowering therapy. And their number needed to treat was 8.5 for moderate and 3.6 for large weight reduction. So, based on these results, we believe these results highlight the potential role of the moderate to large weight reduction in controlling serum urate level.
Hmm. Yes, and that's a very interesting finding. I wanted to add just something really very quickly, and that is to our American listeners, because kilograms is, of course, the way the most of the world weighs objects in general. In the United States, 1 kilogram is approximately 2.2 pounds. And so, to give a rough conversion, so about 20 kilograms of weight would be about 50 pounds of weight. So,
Mhm.
it just gives a little bit of an idea for how much weight loss would be necessary to affect how much decrease in uric acid levels. And so that really gets to the heart, the conclusion of what you had mentioned. I want to delve a little bit into the methods a little bit, and I was really intrigued by this database that you used, the St. Luke's Health Checkup database. Can you tell us just a little bit about this database and how you used it in the study?
Yeah, thank you so much for mentioning our database. This database is a kind of a collection of the detailed data on participants who joined annual health checkup program at St. Luke's International Hospital, Tokyo, Japan. And in Japan, we have a very unique health promotion program, which is called annual health checkup. And all full-time employees should undergo annual health checkup, where we checked medical history, treatment status, height, weight, vital signs, and laboratory tests, including the serum urate and so on. And also, participants are required to fill out the lifestyle questionnaire during the examination. So this is really unique data set because participants' data and the serum urate results within the same participant were followed annually for many years. So in the current study, we repeatedly examined the association of weight change between the two consecutive visits with serum urate change between the two consecutive visits by using the statistical model that can consider interpersonal correlation.
Right. And I'm glad that there is such a program and it's so unique because, in my experience, most wellness programs here in the States are pizza on faculty meetings or something like that, and very little else. That may contribute to gout, actually, depending on how much pizza you eat. So, delving further into the St. Luke's Health Checkup database, you used a lot of variables in here, covariables, covariates rather, and change variables. Can you
Mhm.
tell us why you use these particular variables in order to make your model?
Yeah. As you know, because serum urate levels can be affected by various factors, including kidney function, diet, medications, and so on, we need to consider these variables in the analysis. So we adjusted for example, BMI, serum urate level, age, sex, smoking status, alcohol, kidney function medication, and the results of the dietary questionnaire at the prior visits of the two consecutive visits. In addition, our study uniquely adjusted for the changes in the kidney function, changes in the medication, and semi-quantitative changes in the diet between the two consecutive visits to account for the changes that concurrently occur with weight changes. We believe this adjustment is very useful to see kind of the more direct association between weight change and serum urate changes.
Yeah, you're absolutely correct that, having this model controlled for all these different things is exceptionally vital in order to get an idea of what's going on. Just as importantly, I was taken aback by your inclusion and exclusion criteria with certain people on certain medications and certain diagnoses not being included. Can you tell us a little bit about the reasoning behind that?
Yes. From the methodological, epidemiological perspective, multiple versions of treatment, what we call, is a very inevitable problem when we want to use a weight change as an exposure. For example, patient may lose their weight because of their advanced cancers or use of the diuretics, and they can also gain weight due to their severe heart failure or severe kidney dysfunction. But these weight changes by these diseases and treatments are out of the scope of this study. So to exclude the possible weight change by these conditions, we excluded patients with these conditions from our analysis.
I was particularly intrigued by one thing, mycobacterial antibiotics or antibiotics against mycobacteria. I don't know whether if that directly relates to the experience in the United States, but why in particular were these folks excluded?
Thank you so much. As you know, tuberculosis and mycobacterium infection is more common in the Japan and the Asian country, and that kind of the chronic infection can cause a weight loss. This is the first reason I excluded this patient. And the second reason is that some of the medications used for the mycobacterium infection can affect the serum urate level. So this is the second reason I excluded these participants.
And that is absolutely fascinating because we often forget that in our clinics that there are so many different medications that affect uric acid levels and adjusting those medications and adjusting urate lowering therapy doses is really important. In other words, it's important to individualize and to know the
Mm.
patient and to apply those guidelines. So, in a nutshell, if you could describe the results of your findings, something brief enough that could be on a bumper sticker or sign or a tweet or whatever it may be called nowadays, what would you say?
Okay, yeah. The most important and brief message from our study is if you want to improve your serum urate, make sure to lose at least 5 to 10 kilogram with a firm commitment is a message
And that would be about 11 to 22 pounds, I think, right? By my conversion.
based
Back.
on, yeah, pound. Yeah, I guess so.
And I didn't even think about this a little bit earlier, but Japanese culture puts a value on concinnity and brevity. And one of the things that Japanese culture is known for is haikus, these small poems that have 5 syllables and 7 syllables and 5 syllables. So after I read your paper, I felt inspired to write a small haiku to figure out these conclusions. And I'm not a poet and I don't know Japanese, but here's my haiku. Shedding pounds lightly. Uric acid shifts just so. Great loss finds its mark.
It's really good. Yeah, I totally agree with you.
Yeah,
Wonderful.
thank you. Thank you. I think we need to have more poetry in all of our journals, just in general. That's my editorial comment. I wanted to also talk about a few other of the things that you had mentioned in your article, and you cite the multiple risk factor intervention trial. The one with the really fun to say acronym, Mr. Fit. Can you explain to listeners about how your results are similar and how they are different to those from Mr. Fit?
I see. I now understand it's called Mr. Fit. Okay.
I think
So
it's supposed to be called Mr. Fit, but
okay. Yeah. Yes. The secondary analysis of the Mr. Fit trial is a most important similar previous research, which is conducted by the Professor Hyun. He's a professor of the Mass General Hospital and also co-author of our project as well. And our study is a kind of the extension of the secondary analysis. And we found the extent of the change in the serum urate by small, moderate, large weight reduction is very similar to those in the trial. But we have several differences. First, we uniquely reported relative risk and the number needed to treat for achieving target serum urate level in those with hyperuricemia. And also, population is very different. MRFIT included only highest atherosclerotic risk male patient, as far as I know. And many of them are severely obese and had multiple CVD risk factors. In contrast, our population is relatively healthy Japanese people and included both males and females. And second, our study is purely observational outside of the intense intervention. MR Fit, a Mr. Fit, is a trial. So patients received intense dietary intervention and the treatment to improve their lifestyles and their comorbidities. But the participant in our study did not receive such kind of their interventions. Only they received mild advice from the physician based on the health checkup results. So our study found many people with hyperuricemia reduce their weight like spontaneously and without intense intervention and improved serum urate. And some of them achieved target serum urate level. So this is really important finding of our study.
absolutely. And you really helped shine why it's Mr. Fit because it only had men in the inclusion criteria, right? Okay. And I wanted to ask another question, and we've covered this just a little bit, but it's worth reinforcing. You mentioned in the paper that weight reduction may be an effective strategy to improve SU, that is serum urate, levels in patients with gout.
Mhm.
Can you summarize or emphasize once more how much weight a person would have to lose in order to achieve target serum urate levels?
It's really important question and a clinically relevant question. So first, I want to emphasize that moderate to large weight reductions, a substantial weight reduction is required to achieve the target serum urate on average. And also, it's really important to consider hypothetical patient. So, okay, let's say you're a physician and you are trying to manage serum urate level in your gout patient through weight reduction, and the patient BMI was 28 and serum urate was 7. And in the patient, based on our estimates from our study, serum urate would decrease by 1 milligram per deciliter on average when the patient reduced weight by 10 kilograms. So I can say this patient may achieve the target serum urate level by 10 kilogram of the weight reduction. And also, this simulation at the same time suggested it seems a little bit difficult to achieve the target serum urate level only with the weight reduction if the patient has very high serum urate level, like more than 8 or more than not higher than 9. So I'd like to emphasize that it is also important to timely start lowering therapy appropriately in those patients.
Yeah, and in fact, when you think about it, losing 20 pounds is not an easy task for
Yes.
any individual.
Yep. I
So
totally agree.
yeah, exactly. Again, to highlight this, this is a very fascinating study. And of note, it was conducted in Japan. And our listeners tend to be more from the United States.
Mhm.
Can you discuss how the geographic context informs what we can take away from your study?
Yeah. First, I agree that considering the transportability of the results is really important in the clinical research. And first, Japanese people were much smaller when compared to the people in the United States. So I want to say 10 kilogram weight reduction in 50 kilogram patient and 10 kilogram weight reduction in 100 kilogram patient may have different effects on the serum urate level. So we need to be careful to interpret the results. But as I mentioned, Mr. Fit trial also showed similar extent of the serum urate improvement in males in the United States. And second, we need to be careful in interpreting the number needed to treat in our study. Because while our study showed that the number needed to treat to achieve target serum urate level for moderate or large weight reduction were relatively small, like 8 or 3 in our population. But in our population, most hyperuricemia is mild, like a serum urate level of 7 or 8 or something like that. But I guess in the United States, more patients may have higher serum urate level than Japanese population. So in this patient, it may be difficult to achieve target serum urate level only with a weight reduction. And regardless of the geographic context, I want to emphasize here that a slight weight reduction is not sufficient and the substantial weight loss is necessary. So if patients want to improve serum urate levels through weight reduction. So I think it's really important for healthcare professionals to be aware of these results and also should not merely suggest weight loss lightly to the patient, but rather they need to firmly encourage patients to commit to their substantial weight reduction and the behavioral changes with kind of the strong mind.
Yeah, I agree with you. And, the two words that really strike me are substantial and commitment. And that kind of brings me to the next question because, for the most part, in the past, apart from lifestyle changes, it's been mostly bariatric surgery and a few medications here or there.
Mhm.
But now there's a lot of excitement about GLP-1 agonists and their potential role in addressing obesity. Does your study shine any light on how GLP-1 agonists may impact serum uric acid levels and risk of gout?
Yes, I hope so. As far as I know, despite some conflicting evidence, previous studies generally suggested GLP-1 agonist has modest urate lowering effects and mild gout risk reduction. But the effect seems to be a little bit limited when compared to the other medication like SGLT2 inhibitor. But our data, our results indirectly support the urate lowering effect of the GLP-1 agonist through weight reduction. And furthermore, interestingly, an article about the effect of the anti-obesity medication, like Oristat, on the gout risk was published in the A&L this month in the same issue with our article. So the combination of the results of these articles, my articles and that article, provided the potential importance of the weight reduction in gout patients.
And that is a wonderful reason why listeners, you should read A&R and ACR and the rheumatologist page to page, cover to cover, because you never know what you may find. And those are real gems out there. So I think that this actually is a good point to mention that you've really helped to clarify that relationship between weight loss, and uric acid levels. With these kind of tantalizing insights, where do you want to take this into the future?
Yes, thank you so much. First, as we have shown in the histogram of our article, it's a figure of maybe 1 or 2, there was a large effector heterogeneity of the weight reduction on serum urate changes. So it's really important to identify kind of the high benefit population for recommending weight reduction to improve serum urate level. And second, our study results suggest that in cases of mild hyperuricemia, it may be possible to achieve the target serum urate levels solely through weight reduction without urate lowering therapy. So it is really important to investigate whether weight reduction without urate lowering therapy can effectively control serum urate levels in patients with mild hyperuricemia without increasing the risk of gout flares. And third, how to achieve weight loss is very crucial problem, as you mentioned, because, losing weight is often very challenging. And the anti-obesity medications can be the important option. And also research on strategies that help patients commit to weight loss and maintain their motivation is also important. And also, even in patients treated with an urate lowering therapy, it is important to reduce weight to minimize the CVD risk and their potential overall health risk. if the patient is overweight or obese, which is common in the gout population.
Absolutely. These two words that you had mentioned keep on going through my head, substantial and commitment.
Yeah.
And I think that those are going to be the two kind of the drivers when I have conversations with my patients
Yeah,
who have
thank you
gout,
very much
that
for repeating, these words.
substantial and commitment. We'll drill that into our listeners' heads. I also wanted to mention, I did a little bit of background research on you in addition to the article. And, you have been extraordinarily productive. And your work spans a lot of different clinical, translational, and even health systems research topics. I think there was even medical education articles you were
Exactly.
co-authored on.
Yeah.
Yeah. Without giving too many spoilers, what kind of amazing work are you and Dan Solomon? What are you guys up to nowadays?
Okay, thank you so much. Yeah, I'm currently working on several projects, including serum urate, gout, and kidney function in rheumatoid arthritis patient, and other public health studies. And I'm doing several research to examine the association of the lifestyles or biological changes with serum urate changes, like this study. And there also kidney function research in the patient with rheumatoid arthritis is really interesting because it's really important and clinically relevant, but apparently understudied area, I think. And lastly, I'm recently interested in the women's health from the perspective of the public health. This is not directly conducted in the patient in rheumatology, but I believe this is really important in many patients with rheumatic diseases. So I have many preliminary results that are really fascinating and interesting. So I'm very looking forward to publishing and sharing more information in the near future.
And I am absolutely enthusiastic to read those articles and absorb all of that because those are all very, very interesting to me. And yes, I agree with you. These are completely understudied, criminally understudied for whatever reason. I'm very glad that you are taking the initiative to help shed some light on all of these things. And that brings me to another thing that I want to know. So, how do you have the time to do all of this? What super potion are you drinking, and what do you do in your free time if that exists?
Okay, thank you. Yeah, if I had a super portion, I'd like to share it. But in truth, I'm very lucky to have a great mentor, Dr. Dan Solomon, professor at Brigham and Women's Hospital. And he always gives me wonderful mentoring and support. And also, Dr. Okada and Dr. Kishimoto, they are my Japanese clinical supervisors, also supported me so much. So I'd like to say I can do my work thanks to the wonderful collaborators and great team support. And regarding the free time, I don't have so much free time because first I'm working hard and I have a small child and I'm a father in training. And also my wife is pregnant. so,
Oh,
so if I have free time, I play with my 2-year-old boy and try to do housekeeping work as much as possible. So yeah, thank you so much for the interview.
well, that is number one, wonderful news to hear. Congratulations. Again, like those two words that you had mentioned earlier, substantial and commitment, they're not just important in weight loss, but in mentorship, what you're mentioning, and in parenting as well. So I think that these things, they cross boundaries in many different ways that we don't expect them to. I mean, this interview, the pleasure has been all mine. I absolutely loved reading your article and I loved hearing your further insights on the podcast. So I'm very, very, very grateful for your time.
Thank you.
So thank you all for listening to this podcast. We will see you next time or in haiku form. Thanks for tuning in. ACR Journals on Air. Rate us, subscribe, share.
Wonderful.
ACR Journals on Air is a podcast of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts. Thank you and take care.
Thank you.